Coming up today, the risk of developing serious medical conditions goes up for every woman at one single point in her life, the moment she starts losing estrogen. Today, we explore what science is teaching us about women's bodies as they approach menopause and how far we still need to go in recognizing this inevitable time in every woman's life. Good morning, I'm Jessica Lovell, and welcome to the Morning Medical Update. We have an impressive panel of physicians who are experts in menopause. These women help their patients navigate the uncharted waters and sometimes stormy seas of this life change. In studio, you may recognize this national best-selling author, physician, and Menopause Society certified practitioner, Dr. Mary Claire Haver. She is in town. She was here last night to share more about her latest book and the findings in the book that was recently published called The New Menopause. Always great to have you. Great to see you.
Thanks.
Great to see you again. I know you had a big turnout last night, so thank you for making time for us this morning. Our audiences will also recognize Dr. Carrie Winicky, Clinical Service Chief of Obstetrics and Gynecology here at the University of Kansas Health System. And joining us virtually is OBGYN Dr. Madhuri Reddy. Both are also Menopause Society certified practitioners. Great to have both of you. Welcome, everyone. Well, before we get real with menopause, we're going to get teal in our morning rounds. The University of Kansas Health System is cheering on the Kansas City Current heading into the National Women's Soccer League playoffs. It's this weekend. Very exciting time. The club has had a fantastic first season in that brand new stadium. And as the official healthcare provider, the health system has been keeping players safe and in shape. We are joined by Dr. Nicole Linsky, Chief Medical Officer for the Kansas City Current, as well as a family medicine and sports medicine specialist here at the health system. Good morning. Good to see you.
Yeah, good to be here.
Exciting time, busy time for you.
Very busy, very, very exciting.
Yes, and you've been with the team all year. So does entering playoffs change your workflow at all?
Not very much at all. Just really staying focused on keeping our players healthy and sustaining that winning mentality.
So every single home game has been a complete sellout. What's it like? What's the energy like when you're down there on the sidelines?
It is absolutely electrifying to see the enthusiasm and the support for our current athletes. It's been really fun to see.
And we love this. The Current is donating money to the Adelaide C. Ward Women's Heart Center here at the health system for every goal scored. That is good news for us. The Current have scored more goals than any other team in the league, a record. How much has been raised? And then most importantly, where's that money going to go?
Yeah, so the Current, like you said, has scored a record number of goals, set the league standard at 57. So that'll be $57,000 going to support heart health, which is also near and dear to women for making sure that they stay healthy going forward.
I'm hoping one day I cannot ask you this particular question, but from your perspective, does it feel like women's sports is being taken more seriously?
Yeah, absolutely. We have seen really what it means to invest in women's sports, not just for the NWSL Soccer League, but also for the WNBA, and the support that we've seen and the focus really. And really what we've seen come out of it is what happens when you invest in women's sports is you really get this fantastic experience of seeing how women can compete on this stage, and it's really been great to watch.
Such an exciting time in Kansas City sports across the board this whole year, right?
Yeah, really.
Well, good luck. More importantly, just have a really good time, Dr. Linsky.
Yeah, absolutely. It'll be great.
It will. Thank you so much. Well, menopause is as old as time, and so are the stories passed down from generation to generation. And then there are the many questions from women wanting a better experience than what their mothers and grandmothers went through. We heard some of these stories, these questions, and frustrations recently from women in our community.
Why is the word men in the word menopause? I mean, why don't they go through it? You know, I don't know.
The hot flashes, the hormones, my hormones were just like through the roof. I was just so irritated and It was a lot. It was a lot.
All the symptoms that you go through, you know, the hot flashes. In the middle of the night, you go to bed and you're cold and you cover up, and then all of a sudden you wake up in the middle of the night completely soaking wet.
When you get hot, it's like an inside burning, and it's like hard to cool yourself down. And you just go through all these crazy emotions of standing in front of the refrigerator or sticking your head in the freezer, and it's like you want to cool down so bad, but your insides is like on fire.
I think it involves more than you think, because everybody's like, oh, you're gonna have hot flashes. It's joint pain, it's all kinds of stuff. I think it's more widespread inflammation from it.
The body changes, the dryness, sometimes the achy. It hasn't been really bad, but I kind of wish I knew about some of the things the body was going to go through and the changes. I've gotten to the point where I've started recording them on my calendar. I was like, this happened that day, this happened that day. It's been interesting.
You can see weight gain in people, and you can see like, oh gosh, she's losing her hair, but you don't see in your people like, she has no sex drive anymore.
The joint pain, I did not expect the joint pain. It was in my knees and my shoulders mostly, but a lot in my shoulders, and I wasn't expecting that.
I didn't have family members who knew their timing or knew what happened because of different medical reasons, and so I didn't know at all what to expect or when, and so yeah, I think it would have been really helpful to know a lot more about just the range of things.
I just think that I listened to too many of my girlfriends without me just kind of really like tuning into my own body. And also, I'm of the generation where most of our moms got hysterectomies back in the day. That's just what you did. And obviously that's not a thing that much anymore. I just kind of compared myself and did maybe what some of my friends were doing, and it didn't work out so great for me.
One of the things I learned, one of the doctors is like, you know, they spend about 5 minutes talking about women's health and menopause in medical school. And so, you know, this was a specialist in menopause, and she's like, everything that I know, I had to learn after medical school.
I wish there was more options for medication to help control it, and I wish there was more of a conversation before you got into menopause.
I've got a lot of younger friends right now that haven't experienced it yet, and so we just kind of laugh about it and say, well, just wait. We'll talk about it when you get there.
We're all gonna get there. I'm taking it, that all sounded very familiar, right? Yeah. Dr. Reddy?
Yes, absolutely.
Yeah, that, and I'm sure many other types of symptoms. We mentioned at the beginning of the program that you all are Menopause Society certified practitioners. What does that mean? Who wants to jump in?
So the Menopause Society is a group that was founded to study menopause. In the American College of OBGYN, there's not a specific branch to study menopause, and it tends to get overlooked. So this was done decades ago of a group of clinicians who were interested in just forming a society around the study of menopause. And in the last few years, they've created a certification program. And they have a wonderful workbook with all of the latest updated, information about risks, benefits of, different options for treating menopause and all, kind of rounds up the latest research going on. And there's a certification exam to pass to make sure that you're competent.
Well, then we've got the right panel lined up today, so we're glad to have you all. And you've heard it all, and likely agree that women have learned to dread this time in their lives. You've heard those women say it there on the tape. We hope that by the end of this episode, that you're feeling a little bit more hopeful and educated about where to turn and what to do next. So, Dr. Haver, let's start with you. When menopause happens, in your book, you say that medicine identifies menopause as a single moment in time. What do you mean?
So menopause medically is defined as 1 year exactly to the day after your last final menstrual period. And so everything before that is premenopause or perimenopause in the transition, and everything after that until we die is postmenopause. So actual menopause is really just 1 day.
Many women, they're going to say that symptoms take years to come, and then it certainly feels like, it always feels like years to go away. What does the science show?
So it depends on ethnicity, it depends on your overall health status, it depends on weight, socioeconomic factors. But it turns out that, we've really defined menopause medically by vasomotor symptoms, which are the easiest thing to kind of assign to menopause. Not a lot of other things in our health can cause these hot flashes, night sweats, and what we call vasomotor symptoms. But actually, menopause affects every organ system of our body, but that's the one we kind of hallmark. So for example, for Caucasian or for white women, we tend to have 7 years of vasomotor symptoms on average. However, for African American descent, you are looking at probably 8 to 10, maybe 11 years on average. So some women have much longer, some women may have shorter.
So we hear of the hot flashes, lack of energy, the brain fog, and oh my gosh, the weight gain. Dr. Linsky, I'll start with you. What are some lesser known symptoms that maybe you've heard from patients?
Oh, where to start? I mean, because there's so many, right?
Well,
so
yeah, and they can be mistaken for something else. That's why it's so confusing.
As I'm sitting here this morning doing this, lots of joint pain. We hear a lot of shoulders and knees. We hear GI changes. We hear a lot of brain fog, mental kind of slowness, recalling things. Of course, sleep is a big one. Lots of sleep disturbances. Weight gain we've talked about. Of course, vasomotor symptoms. Vaginal concerns, vaginal dryness, vaginal itching, vaginal pain. You could almost go through eye changes, vision changes. You could go through almost every organ system, and we could list 4 or 5 at least that are associated.
I was going to say, okay, so to answer, I think I hear you saying any and all things that could go wrong, it could be menopause.
Right, and that's because we've come to learn that there's really estrogen receptors everywhere in our body almost. So when that changes, then everything that has an estrogen receptor is going to change as well.
Dr. Haver, anything unusual from patients that you've heard that we should look out for?
She covered a lot of them, but skin, hair, nails, anxiety, palpitations. Like a lot of ER docs are coming to me and saying, these women are coming in, they're somewhere in their 40s, 50s, 60s sometimes, and they're coming in thinking it's a panic attack or maybe they're having a heart attack. And really it is a really serious vasomotor symptom. So, and the anxiety around that happening again and not knowing what to do about it. And so they get these extensive cardiac workups or go home with Holter monitors, which is appropriate to work up these symptoms, but no one's kind of connecting the dots or haven't, but now that the information's getting out there, we're having a better understanding. Now, like the first line of women going into the ED, these emergency doctors are starting to understand that, okay, we've ruled out heart attack and these other serious conditions. This might be your menopause.
How do you keep track
of the symptoms?
Yes.
One woman on here, we were all shaking our heads when you were showing this video because she said, I keep them on my calendar, and that's a great way. Most of us don't go far from our cell phones, so you can track on a calendar, you can track on your notes. There are symptom trackers. Dr. Haver's book has one in the back that you can link to. You could Google online menopause symptom tracker, long list of symptoms, and you could put how many days are, how strong they are. And I also find that really helpful because once we start treatment, then we can really track if we're helping certain things. Sometimes when we start some medications, what was a lower bothersome symptom, if we can help some things that were, there all the time, other things kind of bubble up, and that helps us track those a lot. So there's lots of different ways out there.
Dr. Haver, what's your advice for tracking and where to track it, how to track it, and why is it just so important?
Well, to see how you're responding to medication mostly, and to have talking points to discuss with your clinician. So, and that, here are my treatment goals. I would like to sleep better. I would like for my hot flashes to get better. I would like for my joint pain to get better. And there's no guarantee that hormone therapy or other pharmacology will be the cure for these things, but it is definitely a way to monitor how your symptoms are doing. So we have a tracker in the back of the book. We have some online options through our website at thepauselife.com. But I think it is important for you to monitor and know so that you can have a really clear conversation with your healthcare provider.
Great tip. Dr. Reddy, I want to bring you into the conversation. The women that we spoke with, they suffered from some of the same symptoms, but in some cases, they were in different ways. Some said that the hot flashes were actually warm flashes mixed in with like really bad brain fog. The good news is that most women don't suffer all of these things and all at once, but do we know why some women suffer more than others?
Yeah, that's a good question, and it's a very frustrating question sometimes because we do not really know, why some women suffer more. There's a tendency sometimes that the menopause may be similar to what your mom went through, but I don't think you can really take that to the bank. So it's more, and also the more frustrating thing is there is no a level you can say that if you check hormone levels, this level will be this symptom or anything like that. So a lot of times there's not a good way to tell who will get what symptoms. And that's the reason why I think it needs to be very individualized when you talk to the patient and how you treat the patients.
So, Dr. Haber, in your book, you talk about the lack of scientific study around menopausal medicine. You described research went wrong over the past 20 years. What has gone right?
So we had a kind of a landmark study. It was really exciting that finally aging women were being studied. And this was 22 years ago with the Women's Health Initiative, which actually started 4 years before that. And it was really designed to see if we knew from observational studies, just looking at women who took hormone therapy versus women who didn't, we were seeing better cardiovascular disease outcomes and better quality of life, as well as lower all-cause mortality in the population that was taking hormone therapy. But that's just observation. That's not proof. Proof is a randomized controlled study. So this was a huge, large-scale, tens of thousands of women going in to see if it was actually protective for cardiovascular disease. And the design was starting with a much older population than we tend to start hormone therapy. The average age was 63. And so when they started them on hormone therapy, they only used 2 specific medications. If you had a uterus, you got something called Prempro, which was Premarin plus medroxyprogesterone acetate, and if you didn't, you just did Premarin alone. And so then the outcome of the studies, they stopped the study early because the arm with the progestogen had seen a very slight, not statistically significant increased risk of breast cancer, called a press conference, pulled that genie out of the bottle and scared the entire world away from hormone therapy that it caused breast cancer. Well, that data has been reanalyzed, deaggregated, looked at it based on age, and it turns out the estrogen-only arm saw a decreased risk in breast cancer, but it really has perpetuated through press, through media, through medical teaching, and it stopped really most meaningful studies around aging women and hormones. Until now, we're starting to see a resurgence. The interest, this Generation X is not putting up with this. They don't want to suffer like their mothers did. They're not going to do it quietly. They're demanding more options, more treatment, more therapy. So we're seeing increased interest. Every day I get a PubMed alert on every article that comes out with menopause or perimenopause, and it's getting bigger and bigger and bigger, and it's worldwide. So we're starting to see more information, more education. There was the Women's Health research funding for $150 million that just got signed in a few months ago to increase funding and education around women's health outside of reproduction.
And you say, women now not wanting to put up with what moms and grandmas put up with. I don't even remember the word menopause being brought up growing up. I mean, my mom had a hysterectomy, so it just wasn't a conversation. It really was not until you got older and you could start Googling things and finding out what in the world is going on with my body. But so the hope is coming in the way of people paying attention.
Right, and my daughter is in medical school, so she's a second-year medical student, and she is now again, I'm her mother, so it's a little biased there, but she is really hyper aware of not only just talking about menopause and hot flashes, but the gender health gap. I mean, this is a bigger conversation than just hot flashes. This is women are less healthy than men after menopause. And we are having poorer outcomes overall, poor quality of life, more nursing home admissions, higher cognition deficits, and much higher frailty risk. And how do we, menopause is kind of a starting point, but really talking about how do we age healthier?
Well, menopause, it just seems like it's always been just kind of like a punchline. I mean, it's just something, you talk about. I mean, I think they even have, don't they have a musical about it or something?
Menopause the musical?
Yeah, I mean, so it's, I think it's something that has kind of been brushed away and something like, you deal with it quietly and just deal with it. So not today, though.
And that impact, I think, has affected generations of physicians as well.
True.
Because when people weren't talking about or asking for it, and, when the WHI came down, we really weren't educating about it either. So, I remember I went probably 6, 7, 8 years without ever writing a prescription for hormone hormone therapy at all, just because no one talked about it, no one asked for it, no one was comfortable doing it. So now we're really kind of starting off at that kind of ground zero again. It's really exciting, and that's, I think, as Dr. Haver said, it's pulling in the need to identify women's health outside of just general reproduction too.
Dr. Reddy, where do you stand on hormone therapy?
Well, I stand on saying that majority of the people are safe to take it, and I think we should prescribe it a lot more than we normally do. I think the legacy of WHI still lives on in some of the physicians who are not dealing with menopause all the time. So I think we have to fight that, and I think and I also let the patients know that it's an option for you, and it's a safe option. You don't have to suffer through the symptoms.
And we hear a lot about bioidentical hormones. What does that mean?
Bioidentical hormones technically means that the hormones that you are taking are chemically identical to the hormones that your body would normally make. And then there are some places where they say compounded bioidentical hormones. Those are the hormones that are made in the compounding pharmacies. They have a whole different kind of connotation because they're not approved by FDA, so they may have issues with the levels in each dosing and things like that. But bioidentical hormones by themselves just means chemically they're identical to what your body is making.
Dr. Haver, you are also a certified culinary medicine specialist in medical nutrition. I'm going to start with you because actually last night I was Googling foods to eat to help you lose weight when you're in perimenopause. It's actually on my phone. I was scrolling and trying to find anything, and I'm like, I already eat that, I already eat that, I already eat that. So does it matter what we eat when we're going through perimenopause and menopause?
It matters what you eat at all times of your life. And what's special about perimenopause and menopause is that we're seeing increasing inflammation just with no changes in diet and exercise. A woman can expect to have increasing changes in her visceral fat, and so just from the hormone changes. So premenopausal women age match. So we all go through menopause at different ages. Kind of thank God, because it makes the research easier to prove these things. So if take 50-year-old women, some pre, some postmenopausal, right? The premenopausal women can expect to have 7% of her total body fat to be visceral, which is the intra-abdominal fat around our organs. You take that woman through the menopause transition, that will increase to 23% with no changes in diet and exercise. Why do we care? Because visceral fat is biologically more active and more inflammatory, and its higher amounts of visceral fat are linked to hypertension, diabetes, stroke, and 7 of the top 10 causes of death in women. So what can we do nutritionally? So we know, looking at the data on the menopausal women who were studied, women who have diets higher in fiber, so 25 grams or more daily fiber per day, and most of that fiber should, if not all, should come from food. And so, they've looked at African American women and cognition scores and fiber intake. The benefits seem to max out for women around 32 to 35 grams per day. So and most women are getting 10 to 12 grams in the Western diet. So we have, a lot of things we can do there with just increasing fiber intake. Watching your added sugars. Sugars have gotten a bad rap through the keto movement, but sugars found in natural foods, fruits and vegetables, and dairy actually is wrapped up with so many other nutrients, protein, anthocyanins, vitamins, minerals. And fiber, you blunt the effects of the rise of sugar in your bloodstream, so your insulin levels are lower. So women who limit those added sugars added in cooking and processing, and alcohol, to less than 25 grams a day tend to have less visceral fat. There's been some decent studies looking at probiotic intake, either through supplements or, but I prefer my patients to get it through food if they can. Supplements, and this is a doctor who sells supplements, so full disclosure, should never take the place of good nutrition. Your nutrition goals should come from food, and we only supplement when there's gaps.
Thank you for explaining the science behind the foods that we eat and why they're so important. We know that you have questions out there. You can use the chat on YouTube or Facebook. You can email the Medical News Network. All of that information is there on your screen. Dr. Reddy, how do you want patients to prepare themselves for their visit with you?
That's a good question. And I think, I'm a menopause person. So somebody coming with menopause, I know I am, willing to, I want to give you hormones. I want to make sure your life is better. But I think what helps me knowing is the past medical history. Like if there is hypertension, how is it being treated? If there's coronary artery disease, what's going on? What stage is it at? What's the family history in terms of heart disease, cancers? If you yourself have cancer, what type? Those kind of things are very important. Of course, symptoms. I want to talk to you about to find out the symptoms, but I think it's nice to know sometimes there's a wide variety of symptoms, and sometimes when they're in front of the doctors, some patients will forget a few things. So it's nice to have a written down, and also questions. I think questions to ask to the doctor, if you write it down, you won't forget to ask them. So I think those are things I would suggest patients to do.
We have heard many, many times, too many times, that women often feel overlooked, not heard when they go in to talk with their doctor. Dr. Linsky, how does a woman find a menopause specialist who will actually listen?
Mm-hmm. Well, I think we talked a little bit earlier. I think there's a couple different ways. I was going to say the North American Menopause Society, but now a new name. I have to retrain myself. The Menopause Society website, you can look on there. You put in your zip code or address, and it will have two different types of providers on there. The first of which is someone who says, hey, I have an interest, and I've signed up to join this society. And then there's those that are certified, as Dr. Haver mentioned earlier, who have passed a test and have to continue on CME, or continuing medical education specifically for menopause. So that's a great start. Dr. Haver's website does have options to look for the same sort of way about local addresses and patient testimonials, and then ask friends. I frequently, my patients will I'm going to tell my friends about you, and then the next person comes in, well, you know who told me, and suddenly you're like, gosh, I want to go to that book club, Right. But it's just word of mouth, I think. But if you don't have that, I think it's always better to have someone local. We do a lot of our telemedicine by telehealth, but if you're local, then if something happens or you need that exam, we're here. But if you're in an area, I know because people watch the show across the United States, is that if you are in an area that you don't have a provider that has that sort of interest or willingness to listen, there are national telehealth companies that are providing menopause care as well.
Dr. Haver, did you have something to add?
Well, they've started a menopause clinic, which I'm just applauding so hard. It's a new thing, and there's only a few centers across the U.S., and that there's one right here in Kansas. Kansas, Missouri area is pretty incredible that you've done that. So applause to you.
And you're booked up.
We're booked. That's okay. That's okay. That's what we're here for.
It's just showing a need, to increase.
Getting booked. So I want to ask all of the physicians on our panel. Dr. Reddy, I will start with you. What do you think the future of menopausal medicine really looks like?
I think it looks good. Honestly, I'm optimistic. I think the pendulum swings in a lot of the medical kind of things we do. Menopause, definitely the pendulum swung all the way to, hormones are bad. And I think it's swinging back as we get more and more data about it and about how it can be safe and how it does improve women's lives a lot. So I feel optimistic about the future.
Dr. Haver, can you keep the good news going?
Same. I see, in increasing educational efforts across, I lecture to medical schools and residencies across the U.S., mostly through Zoom, so it's pretty special. I get to be here in person. And I see my daughter's in medical school. She is hungry for the information. I think we're not going to silo it to just OBGYN. I think that's a mistake. I think every clinician who touches a female after reproduction should have clinical training in menopausal medicine.
When I see a patient who's been put on hormones through an internal medicine doctor at primary, I send them a little note like, hey, thanks for doing this. This is wonderful.
That's quite a change. That is a change.
It is, because in the past, I think people would walk in and the answer was no, no, no. Prove to me you deserve this. Prove to me. And I think we got to change that kind of mantra. It should be, yes, let's make sure it's safe for you. Let's talk about this. So it's just kind of looking at it a little bit differently.
I want to get to some questions from our viewers because we've got some good ones. Jeremy says and asks, why is there such a difference in length of menopause for different ethnicities?
So we're talking about length of menopausal symptoms. So, menopause is always going to affect your bones for the rest of your life. Menopause is always going to affect your brain, your genital urinary system. The more cliche symptoms, do tend to eventually end, like the hot flashes. So we're not sure. We need a lot more study as to why do different ethnicities, different weight, different body types, different background and upbringing have these differing, symptomatology. And to be clear, hot flashes are a bell ringer. Women who have severe hot flashes have more serious cardiovascular disease, higher risk of stroke, more incidence of diabetes. So it's not just annoying. They're incredibly annoying because I had them, but it's also, a bell ringer for chronic disease.
Listen to your body. Joe has a question. She wants to know, when you have had a hysterectomy in your early 30s, how do you know when menopause should happen? Or if?
Well, as Dr. Haver mentioned, menopause is this day 1 year after your last period, right? And I think that we are so focused on that day, but if we take a step back and talk about symptoms, so I'm less concerned about that day of menopause, but I want to know about your symptoms. So if you don't have a uterus, you're not going to have menses anymore. But let's talk about your symptoms. If you're having symptoms that are bothersome, then we know that you're at least in that transition period or could be in menopause. There are blood tests that can be ordered, but they aren't very reliable and don't tell us exactly things like Dr. Reddy shared with us earlier this morning. So it's really listening to your symptoms.
Stacy has a question. Dr. Reddy, when should one seek their first appointment? At a certain age or after a certain symptom has begun?
I don't think there's a certain year or a certain symptom that needs to bring you, but I think if anybody's concerned about what is happening or what is going to happen in your mid 40s, early 40s, then I think it's a good time to come and talk about it.
Question from Yen Liang is, given the discomforts associated with menopause, such as insomnia, palpitations, hot flashes, we've talked about all these, could maintaining a slightly higher body fat level help in releasing estrogen and ease those symptoms?
No. There's no, amount of body fat is not correlative to symptomatology. And there's a lot of misconception that like estrogen is stored in fat or estrogen is created in fat. There is, fat cells do help, convert some of the precursors to estrone, which is a very weak estrogen. We're getting very technical and we're in the weeds here, but that's I live on social media now, so that is a social media fallacy, and I don't want people to think that maintaining, an unhealthy body fat is going to ease your symptoms, because there's no data to support that.
Good to know. Additionally, also wants to know, can regular aerobic exercise potentially slow ovarian aging?
Well, I think aerobic exercise can be good, but I am unaware of any studies that show that aerobic exercise slows the actual aging process.
So we know things that speed it up. So let's talk about that. There's definitely behaviors and lifestyles that will have your ovaries kind of walk out the door soon, their function walk out the door sooner. So hysterectomy, you can expect to lose, this study floored me when I read it because I'd never heard it before, and I've done hundreds, if not thousands, of hysterectomies, and I'd never counseled a patient. You will lose 4 years on average off of the life of your ovaries because of the disruption of blood flow to the ovaries that come from the uterus. When we do a traditional hysterectomy, you're going to lose 4 years off the life of your ovaries. If you smoke, you're going to go through menopause sooner. If you have radiation, if you have inflammatory, and anything that inflames the internal organs, is going to increase that risk. Autoimmune disease will increase the risk of going through menopause sooner than you would earlier.
Jenny has a question about painful sex. We haven't really gotten into that. We could probably have a whole show dedicated to estradiol cream topically. She uses this because of painful intercourse. Is that the same as hormone therapy? Is it absorbed the same as if you were to take a pill?
So it is a form of hormone therapy, but the systemic, again, we might get into the weeds here a little bit, but the systemic level does not achieve that of a pill or a patch or a cream that we would think of what we would call systemic. So, a person that is on vaginal estrogen does not need progesterone to sort of counteract that to protect their uterus. Someone that's oral or transdermal or something like that, which is more a systemic estrogen, would need that.
Best advice for the sexual effect of menopause? What do you tell
mean
patients?
libido?
Yeah, just anything, everything.
So we have, when we talk about female sexual function, there's typically 5 buckets where a woman will have a struggle, and they could overlap. So there's a relationship disorder, and HRT is not going to fix, hormone therapy is not helpful for that. Well, it depends on the woman. She's sleeping and feeling better, her relationship might improve. There's pain, so we have to address the pain and figure out what's going on there. There's arousal disorder, there is orgasmic dysfunction, and then there is HSDD, which is hypoactive sexual desire disorder. So for desire disorder, which the majority of women who come into my office complaining of decreased libido in the layman's terms, we have 2 kind of buckets. We have 2 FDA-approved medications that are available on the market that work fairly well. One is Addyi, that you take every day, and it was originally developed for depression, but women were seeing an increase in their libido. And then there's Vyleesi, which is an injection that you give yourself about 45 minutes before the onset. And they both work by increasing levels of dopamine. And when our dopamine levels are higher, we're more receptive to stimuli. And then there's testosterone. Testosterone's been studied in postmenopausal women and shown to have really great effects with increasing their desire.
So much great information today, ladies. Dr. Reddy, what would you say is the biggest takeaway for our audience?
Well, I think the biggest takeaway is to find the right person to take care of you. I think we talked about how to do that multiple times, but I think that's find the doctor that is willing to talk about all the options and treat you, individually.
Dr. Linsky, what's the big takeaway?
I think that we're here, right? So can you imagine 20 years ago, 4 women sitting here talking about menopause and painful sex? No, it's not happening. So I think the takeaway is that there is optimism going forward. People are talking about it. There is a lot of great information, new research coming out, and we're trying to flip that mode. Like it's not the bad thing. It's not poison. Find someone that's willing to talk to you about it, and I think the future's bright.
Dr. Haver, thank you for being here. What's the one thing folks watching you really want them to take away?
So menopause is inevitable. 100% of us, if we're lucky to live long enough, will lose the function of our ovaries, but suffering through this is not. It's not. So find a provider, find a clinician who's educated, who can help you through this journey.
Thank you to all of our guests and our special guest, Dr. Haver, this morning. Thanks to all of you for being with us and watching. Share this link with your friends, your family, someone who might benefit from what we have all learned here this morning. We'll see you back here tomorrow. Coming up tomorrow on the Morning Medical Update. From her office to the softball diamond, Carrie Mooneyham isn't alone in her breast cancer battle. I'm Jessica Lovell on the next Morning Medical Update, how she's handling her treatment with a whole school to support her, plus her message for any woman getting a mammogram. Tuesday at 8.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcast. Now everywhere podcasts are available.